So, hello, welcome all the students. So, good afternoon, and today we are here to discuss dermatology, the most important 25 clinical questions from dermatology, which have high probability to be asked in your exams. And exam is just round the corner. बहुत कम टाइम बचा है आपके पास. आप लोगों की तैयारी बहुत जोर शोर से चल रही होगी. So, without wasting much time, let us begin with the most important clinical questions of dermatology. So, I'm beginning with one simple question which was recently asked in your FMG exam. A 25-year-old male presented with burning pain and vesicles. Vesicles are small fluid-filled lesions as shown in the image. The patient also complains of sensation of a spider crawling in the area of the lesion. This spider crawling sensation is known as paresthesia. Okay. Now, what is the probable diagnosis of the above scenario? Now, as you can see, what are the important clues in this question? First of all, pain, vesicles. In the image, it is shown only on one side, that is unilateral, and they are along a particular nerve segment. So this is a case of herpes zoster infection. Why it is not herpes simplex? It is not herpes simplex because herpes simplex is of two types, type 1 and type 2. Type 1 causes herpes labialis and type 2 causes herpes genitalis. And here the lesions are not around lips and they are not around genitals. So it is not herpes simplex infection. Contact dermatitis generally occur after contact to something. Like the most common culprit which causes contact, allergic dermatitis, the most common culprit is nickel. So generally after jewelry, patients start developing dermatitis to nickel. This question was also once asked. So remember that nickel is the most common culprit for allergic dermatitis, while irritant dermatitis is due to detergents, sometimes vegetables. That's why it is commonly seen over exposed areas of females because they are more prone to develop this dermatitis due to detergents and vegetables. So this is irritant dermatitis. Okay. Here, let us again see this image closely. What you can see these vesicles. These are small fluid-filled lesions. All of them are grouped together, and in the question, it is written pain. So, painful, grouped vesicles, very important clue. Okay, and if these painful grouped vesicles are unilateral along a particular dermatome or a nerve segment, which is shown here, it is a case of herpes zoster, also known as shingles. Now, who is going to tell me the drug of choice for this condition? The drug of choice is acyclovir, and the dose is 800 mg, 5 times a day for 7 days. So if your patient of herpes zoster comes to you, how you're going to treat the patient? Give acyclovir tablet, 800 mg dose, ask the patient to take it 5 times a day for 7 days. Okay. Now, if the patient is resistant to acyclovir, can you tell me? If the patient is resistant to acyclovir, you cannot use acyclovir. Then which drug you will use? Famciclovir, valacyclovir, which one you will use? We will not use famciclovir or valacyclovir because those are also congeners of acyclovir. So then if there is acyclovir resistant case, you can give foscarnet. So remember that drug of choice is acyclovir, but if it is written that the patient is resistant to acyclovir, then use foscarnet. Don't mark valacyclovir or famciclovir. Why? Because valacyclovir and famciclovir, when they go in the body, they convert to acyclovir, and the patient is having acyclovir resistance. So we will give foscarnet. Now coming to the second question, very important question. In this question, we are going to discuss 4 important conditions and the 4 important features which are seen here. So Nishant is saying, sir, I have never read dermatology. So don't worry, don't panic. at least do the most important 25 questions which we are doing here. We are going to cover most of the important questions here. Like you can see, I have already told you what is the most common culprit for irritant dermatitis, what is the most common culprit for allergic dermatitis. So such questions are asked. So at least do this and try to revise my notes in a short duration of time. You will be able to answer most of the questions. Sir, please provide PDF at the end of the session. Surely I will provide this PDF, don't worry. But still pay attention. You will get the PDF, but pay attention and try to understand that why the answer is the answer which is we are going to mark. Okay. So, first of all, Wickham striae. Do you know what is Wickham striae? See, Wickham striae is seen in lichen planus. When you will encounter a patient of lichen planus, you will get 5 P's. 5 P's are plain purple polygonal pruritic papules. So plain purple polygonal pruritic papules are seen. And if you closely examine these plain purple pruritic papule, you will get a reticulate pattern. And that reticulate pattern is known as Wickham striae. So Wickham striae are seen in lichen planus. So first D. Now Christmas tree pattern is seen in. Christmas tree pattern is seen in Pityriasis rosea. So second is C. So answer becomes B. So many of you have already answered. So let me tell you, in Pityriasis rosea, if this is the patient, the lesions which start developing, they develop along the line of ribs. That is, they go in downward direction, something like this. So because they go in downward direction, it gives resemblance to a Christmas tree. And such Christmas tree pattern is seen in Pityriasis rosea. Now third is Warnoff ring. Warnoff ring is seen in psoriasis. Now what is Warnoff ring? Remember that if this is the lesion of psoriasis, which is generally erythematous, that is red in color, with very characteristic scaling known as silvery white scaling. So if your patient is having red erythematous lesions with silvery white scaling, probably it is a case of psoriasis. Generally, these are present over extensors. Now, if you take a glass slide and start scraping this lesion, what you will find? You will find a shiny membrane. So a shiny membrane is seen. A shiny membrane is seen. This membrane is known as Berkeley membrane. And this membrane is surrounded by hypopigmented margin, light color margin, hypopigmented margin. And this hypopigmented margin is known as Warnoff ring. And that is what they are asking. Warnoff ring is seen in, it is seen in a lesion of psoriasis. Now, if you remove this membrane, the end result is pinpoint bleeding spots. This is known as Auspit sign. So again, they ask you, Auspit sign is seen in, again, it is seen in psoriasis. So Auspit sign is seen in psoriasis. Warnoff ring is seen in psoriasis. And another important question which was asked in a question your FMG exam, Dr. Eosinophilia have also mentioned here, and that is Geratage test. This is also seen in psoriasis. Geratage test. Do you know what garrot means? Garrot means chilna, to peel off. So like we peel off the vegetables, similarly, when you peel off the lesion of psoriasis, that is the lesion having lot of scaling, silvery white scaling, and when you scrap it, more and more scales comes out. This is known as Geratage test, which is seen in psoriasis. So these are few very important points. Already question came on Auspit sign. Already question came on Geratage test. Maybe they might ask you about Warnoff ring or Berkeley membrane. All these are seen in cases of psoriasis. Coming to the last one, here they are saying cradle cap, and cradle cap is seborrheic dermatitis seen in infants over scalp. Okay, So when seborrheic dermatitis occurs in infants, and when it occurs over scalp, we call it cradle cap. Can you tell me why? Because it is occurring over scalp where we wear cap, and infants lie down in cradle, isn't it? पालने में लिटाते हैं infants को. So cradle is used by infants and it is occurring over scalp where we wear cap. So it is known as cradle cap, that is seen in infants over scalp, and it is seborrheic dermatitis. So answer is very simple and you can easily answer B. And remember these points. Wickham striae is feature of lichen planus. Christmas tree pattern is seen in Pityriasis rosea. Warnoff ring, Auspit sign, Geretich test, all these are positive in psoriasis. And cradle cap is another name of seborrheic dermatitis when it occurs over scalp of infant. Now coming to the third question. A 22-year-old female presented with asymptomatic scaly lesions over her trunk, symmetrical in distribution as shown in the image. So this female is developing asymptomatic, no itching, no pain, nothing but scaly lesions. So there are scales which are present over trunk. Trunk is the most common site. And it is symmetrical in distribution. Symmetrical means on both the sides, bilaterally symmetrical. As you can see, some lesions are here, some lesions are here, some lesions are here, some are here. So they are on both the sides. As you can see, both the sides. Can you identify the disease? So the important clues are before you. You can see female scaly lesions over trunk, symmetrically present. It is a case of Pityriasis rosea. Why? Because I told you a very important mnemonic in Pityriasis rosea, and that is her trunk and cigarette on fire. Her. Why? Because it is commonly seen in females. So this condition is very common in females. It is associated with herpes virus infection. Herpes, human herpes virus 6 and 7. So her, commonly seen in females. Herpes is the associated condition. Herald patch is seen. Herald patch. Another her. So Herald patch is seen in Pityriasis rosea. Another important question. Herpes is having role in etiology of Pityriasis rosea. It is commonly seen in females, where trunk is the most common site. As you can see, trunk is the most common site. Trunk. Cigarette paper scaling is seen, which is also known as collarate scales, collar-like scales. So collarate scales are seen, another important feature. This is a self-limiting condition, so it heals on itself. It heals on itself. It is a self-limiting. And fir tree or Christmas tree appearance is seen. Fir tree or Christmas tree, which I already told you. If you draw a line, the lesions are going in downward direction, something like this. On the other side also. So it gives symmetrical appearance. And the first lesion which is seen is known as Herald patch. And it is having scaling at the periphery, which look like a collar. So collarate scales. So you can see all these are the important clues which are mentioned in the question. The most important points to remember here are and can very easily be remembered by this mnemonic. What is the mnemonic? The mnemonic is her. So it is seen in females. It is associated with herpes virus infection. Which patch is seen? Herald patch is seen. The lesions occur over which site? Trunk is the common site. How the lesions are present? They are symmetrical along the line of ribs on both the side, giving fir tree appearance or Christmas tree appearance. And do you need to treat this condition? No, it is a self-limiting condition. And as you can see, there is a scaling present. And which type of scaling is present? The scaling is cigarette paper like, very fine, or collarate scaling. Why we call it collarate scaling? Because it appears like a collar. So if this is the lesion, the scaling is present somewhere here, as if there is a collar around the lesion. So all these are the important clues to remember about pityriasis rosea. Very important points. Already questions have been asked on Herald patch, fir tree or Christmas tree appearance, which virus have role in etiology, okay, and which scaling is present. Collarate scaling. Simple. Now moving to the next question. 28-year-old patient presented with complaint of a painless genital ulcer. On examination, it was associated with bilateral non-tender, bilateral both the side, it is painless, rubbery lymphadenopathy in the inguinal area. What is the probable diagnosis? Can you tell me? Yes. So it is painless genital ulcer. So chancroid is not the answer, because chancroid have painful multiple genital ulcers with undermined edges. But here there is only a single genital ulcer and it is painless. So chancroid is not the answer. Now we are left with three conditions, and all these three conditions can have painless genital ulcer. But if we talk about the lymphadenopathy, in granuloma inguinale, which is also known as donovenosis, no lymphadenopathy is seen. Instead, pseudobubos are seen. So this is obviously not the answer. So answer is not chancroid, answer is not granuloma inguinale. It is not donovenosis, because here no lymphadenopathy is seen. But here in the question, lymphadenopathy is mentioned. Now we are left with two options. One is LGV, lymphogranuloma venerum, and one is hard chancre. What is hard chancre? See, chancroid is also known as soft chancre, because induration is absent. But in syphilis, induration is very firm and it is present. So hard chancre is syphilis. Now, to answer this question, you should know that which type of lymphadenopathy is seen in these two. In LGV, the lymphadenopathy is unilateral and tender, while in syphilis, the lymphadenopathy is bilateral, non-tender, with rubbery consistency. So now you know that answer is not LGV and answer is syphilis. Why? Because syphilis can present with painless genital ulcer. Lymph nodes are rubbery in consistency, very important. So hard chancre with rubbery consistency is seen in syphilis, and the lymph nodes are generally bilateral and non-tender. So answer becomes syphilis. Now many students here were answering B as the answer. So this is a very common problem which arises in the examination hall. वहां पर हम भूल जाते हैं, confuse हो जाते हैं. And if you ever get confused, it is very easy to diagnose these sexually transmitted infections. So the important clues in the image are single genital ulcer. In the question, it is written painless. Hard genital ulcer. Why hard? Because of firm induration. With bilateral, non-tender, rubbery lymphadenopathy. All these are clues pointing towards syphilis. As you all know, less, you can remember syphilis, less, painless genital ulcer and painless lymphadenopathy. No pain in the lymph nodes, no pain in the genital ulcer. Everything is less. So whenever you encounter a patient of genital ulcer, that is sexually transmitted disease, simply look for that genital ulcer and in the question, see if pain is mentioned or not. If pain is present, then there are two conditions which are very painful. One is herpes genitalis and other one is chancroid. So if pain is present, you can very easily choose any one of these, herpes or chancroid. But painless can be seen in these three conditions, that is LGV, syphilis, and donovenosis. And if this painless genital ulcer is mentioned, then you should look for unilateral tender lymphadenopathy here, bilateral non-tender lymphadenopathy here, which is rubbery, and no lymphadenopathy or pseudobubos here. While in chancroid, the edges are undermined, and here also unilateral tender lymphadenopathy is seen. And here, herpes, which is caused by a virus, have multiple grouped vesicles, and zinc smear is positive. So zinc smear comes out positive, where you can see giant cells, multi-nucleated giant cells are seen in herpes. So with the help of these points, you can very easily differentiate various conditions where genital ulcers are seen. So read the question carefully. First, look for pain. If pain is present, choose herpes or chancroid. If pain is absent in the genital ulcers, look for lymph nodes. If there are no lymphadenopathy, mark donovenosis. If there is unilateral lymphadenopathy, mark LGV. And if there is bilateral rubbery lymphadenopathy, then mark syphilis. Coming to the next question. They are saying, match the Woods-Lamb finding with the associated condition. Erythrasma, pityriasis versicolor, tinea capitis, and ash leaf macules, which are seen in tuberous sclerosis. So ash leaf macules are seen in tuberous sclerosis. So all these conditions can be identified with the help of Woods-Lamb. Now, can you tell me that erythrasma under Woods-Lamp light produces which color of fluorescence? Coral red colored fluorescence. Already question have been asked. Very important. So coral red colored fluorescence. So first B. So obviously answer is not A and D. Ash leaf macules, they appear bluish white. Now in both, the fourth option is A. Tinea capitis produces green fluorescence. Green fluorescence. So this is also not the answer. And pityriasis versicolor produces yellow, orange, or apple green fluorescence. In some books, it is written orange or apple green or yellow fluorescence. So second is C. So these are the colors or fluorescence which are seen under Woods lamp light. Erythrasma, which is a bacterial condition. Erythrasma is a bacterial condition caused by which bacteria? Corynebacterium minutissimum. So this is the bacteria which causes erythrasma. And the most common site is axilla. And under Woods lamp light, it produces coral red colored fluorescence. Pityriasis versicolor produces yellow, orange, or apple green fluorescence. Tinea capitis, very important, green fluorescence. And ash leaf macules, which are seen in tuberous sclerosis, produces bluish white fluorescence. So answer is C. Do you know what is a Woods lamp? Woods lamp emit light of 365 nanometer. The range is So 365 nanometer, the range is 320 to 400 nanometer. And the filter of this lamp is made up of barium silicate and 9% nickel oxide. So Manitwa Sharma is saying that, sir, your notes are so good, small, easy to remember. Thank you very much. And I have deliberately done that because the most important problem of the students is revision. It is their problem is not reading. They are reading whole day, isn't it? So the problem is revision. In the end, what happens if you have very thick notes, lot of things are there in the notes, in the end, you are unable to revise it. And until you revise it, you are not going to remember in the examination hall. So deliberately, I have only included those very important points in the notes which are repeatedly asked in your exams, and they are having high probability to be asked in your exam. And that is the reason why my notes are very short, sweet, and easy to remember, so that in the end, you can very quickly revise them. And even if you revise them 1 or 2 times, you are able to answer most of the questions in the examination hall. I am pretty sure if you have read my notes and if you have attended my class, you are going to answer each and every question in your FMG exam. I'm pretty sure Dharma से तो आपका एक भी question गलत नहीं होने वाला है. So don't get worried about Dharma, at least, but the only request is that at least read the notes and then go in the examination hall. It will hardly take 3 to 4 hours. In those 3 to 4 hours, just go through all the notes and you will be through. Next question is, a 20-year-old female presented with the lesions shown in the image below. She had history of many similar episodes in the past. So this is not the first time. Again and again she developed this. This time, lesions developed after 5 days of high-grade fever. What is the probable diagnosis of the above scenario? So Bhanu Pratap is saying where we can get the notes. So if you have attended my class, we have made the notes. If you have not attended my class, then obviously you can take the help of your colleagues. Okay, so any student who have attended my class in the mist, you can ask them, you can get the photo state of the notes, or you can just go through those notes. So I took class in the mist, so you can contact your friends who are studying in mist. So 20-year-old female presented with lesions shown in the image. What you can see in the image? You can again see vesicles, small fluid-filled lesions. They are all grouped together in this area. So grouped vesicles. She had similar episode in the past, means recurrent, again and again. The time lesions develop after 5 days of fever. After fever. What is the probable diagnosis? Yes, this is a case of herpes simplex virus 1 infection which causes herpes labialis. But remember that though this is infection of herpes simplex virus, it is occurring again and again after fever. So we also call them fever blisters because these blisters usually develop after high grade fever. And we also call them cold sores because these are sores which develop due to the virus which is lying cold in the nerves, means lying dormant. So because this virus is lying dormant or cold and later on it has produced these sores, so that's why it is cold sores. So looking at the image, it looks like herpes labialis, but because it is occurring after fever, we also call them fever blisters. And because the virus was lying cold in the nerves and later on it has produced these blisters, so we also call them cold sores, which keep on occurring again and again after fever. So answer is all. Okay, so this was a trick question. Most of the students must have seen the image and they must have marked A as the answer because it is herpes simplex virus. Very easy. Herpes labialis, all of you know. But remember that recurrent herpes labialis, that is recurrent infection of HSV1, is also known as fever blisters or cold sores. I told you the reason why, because it occurs after fever and the virus is lying cold in the nerves, that is dormant, and that's why answer is all. Okay, so remember, herpes labialis, if it is recurrent, we call it fever blisters or cold sores. Why they occur? Due to herpes simplex virus 1 infection, or so infection causes labialis, reactivation causes fever, blister, cold sores, all are related to HSV1. What is the drug of choice? Acyclovir. So here also the drug of choice is acyclovir. But remember that acyclovir dose is different. Here it is 200 mg 5 times a day, or 400 mg 3 times a day. So acyclovir is the drug of choice for herpes zoster also and herpes simplex also. But for zoster, it is 800 mg 5 times a day. But here it is 200 mg 5 times a day. If 5 times a day is not mentioned, then mark 400 mg 3 times a day. This is same for herpes labialis and herpes genitalis. So in genitalis also, we use the same dose. Next is a patient presented with an itchy papular lesion over hand as shown in the image, which heals leaving behind pigmentation along with mucosal involvement. So not only skin is involved, mucosa is also involved, as you can see in the image. As shown in the image, what is the diagnosis? So itchy papular lesions over hand which heal with pigmentation. Mucosa is also involved. What is the diagnosis? So here you can see itchy means pruritic. So lesions are pruritic. They are papular. Written in the question, they are papular. They are itchy. So pruritic, papular. If you closely see, they are slightly polygonal, plain topped, and slightly purple in color. So these are the 5 P's which you can see in the image. Plain, purple, polygonal, pruritic papule. Another P, it heals with pigmentation. So 6th P, also you can remember, it heals with pigmentation. So when these lesions heal, they leave behind a pigmentation mark. All these are features of lichen planus. Answer is lichen planus. Why it is not leukoplakia? Because leukoplakia is white. Candidiasis is white. And in leukoplakia and candidiasis, generally mucosa is involved, but not the plain purple pruritic papules are seen over the hand. So that's why these are not the answer. And why psoriasis? Because in psoriasis, mucosa is not involved. Okay, so here both are involved. So psoriasis is also not the answer. Answer is lichen planus. So here skin can develop 5 P's. So these are the 5 P's of lichen planus. I already told you, and it heals with the 6th P, that is pigmentation. Now, if you look at the mucosa, you will get one more P, that is pattern. It can be reticulate pattern. It can be white lacy pattern. So white lacy or reticulate pattern is seen. If you look at the nails, another P is seen, that is pterygium. So another P is seen, that is pterygium. And if you examine the hair follicles, that is pila. Pila means hair follicle. You will get hair loss. Which type of hair loss? Scarring alopecia. So remembering lichen planus is so easy. You just need to remember one alphabet. Pterygium over nails, pattern over mucosa, 5 P's over skin, that is plain purple polygonal pruritic papules, already told you. So plain purple polygonal pruritic papules. So these P's are seen over skin. It heals with pigmentation, and pila also get involved, leading to alopecia. So you can remember so many P's in lichen planus. Just remember the P in lichen planus and you can answer the questions, isn't it? So easy. One alphabet, full disease. Lichen planus can be remembered by one alphabet, and that is P. So let us quickly revise. What is seen over the skin? Plain, purple, polygonal, pruritic, papules. What is seen over mucosa? A pattern is seen over mucosa. Which type of pattern? Reticulate or white lacy pattern? Then what is seen over nails? Pterygium is seen over nails. And pila also get involved. What is pila? Pila is hair follicles. So patient have hair loss. That is alopecia. Which type of alopecia? Scarring alopecia. Coming to the next question. A 45-year-old smoker presented to the hospital with a painless oral lesion and white patch that develops in the oral cavity, as given in the image below. So these are painless oral lesions, white patch, patient is a smoker. In the oral cavity, what is the most likely diagnosis? Now remember that candidiasis also appears white, but the answer is not candidiasis. Why? Because in candidiasis, the predisposing factor is diabetes and not a smoker. So candidiasis is usually seen in diabetic patient, immunocompromised patient, but not necessarily in a smoker. It is not lichen planus. Why it is not lichen planus? Because just now I told you that in lichen planus, pattern is seen over buccal mucosa, but that pattern is reticulate or lacy pattern, and it is usually seen over the buccal mucosa, that is the side of the cheeks. So this is not lichen planus. Here pattern is seen. Now, it is oral hairy leukoplakia or it is oral cancer. See, smoker is a predisposing factor for both leukoplakia as well as oral cancer, because oral cancer is malignant, which can be predisposed by smoking, and leukoplakia is also a pre-malignant condition and it can also occur in a smoker. But answer is not oral cancer. Why? Because oral cancer, that is the squamous cell carcinoma, have exophytic growth. It have exophytic growth. So there is a growth which is coming out, and not just the whitening. The whitening is seen in oral hairy leukoplakia. How to differentiate? Remember, oral hairy leukoplakia, most common site is lateral part of the tongue. Second, it is associated with what causes oral hairy leukoplakia? Epstein-Barr virus. It is due to Epstein-Barr virus. What is seen? A white membrane is seen. But how to differentiate this white membrane from candidiasis? It do not detach on rubbing. So if you take a gauge piece and rub the white membrane of candidiasis, it get detached. But leukoplakia do not get detached. So these are some important clues which point towards oral hairy leukoplakia. Remember, it is commonly seen over the lateral part of the tongue as shown in the image. It is associated with Epstein-Barr virus. Here white membrane is seen, but that white membrane do not get detached on rubbing, but candidiasis can get detached on rubbing. Now coming to the next question, again a very recent question. Recently in the last FMG exam, this question came. A 30-year-old patient complains of an expanding rash which is increasing over groin. So groin of the patient, as you can see in the image, along with thighs of the patient. So groin and thigh of the patient that has become less red and itchy since using the topical steroid. So patient started applying steroid over these rashes. Now on examination, there was a well-defined, slightly raised erythematous plaque, that is solid raised area with central clearing. Very important clue. Central clearing and scaly border. What is the probable cause of above scenario? So Remember that central clearing is feature of tinea. So obviously we know that answer is tinea. Now all the four options have tinea. So which type of tinea? So the type of tinea which occurs in groin, the tinea which occurs in groin is known as tinea cruris. But answer is not tinea cruris. So tinea which occurs in groin is known as tinea cruris, but this is not tinea cruris. Central clearing is feature of tinea corporis, mainly tinea corporis, that is rest of the body. Like if only thigh is involved, we will call it tinea corporis, but answer is not tinea corporis. And because foot is not involved, answer is not tinea pedis. The answer is tinea incognito. And this was the question which was recently asked in your FMG exam. What is tinea incognito? Tinea incognito is hidden type of tinea. And why it is hidden? Because of immunosuppressive drugs like steroids. The most important clue here is steroids. So what patient is doing? Patient started developing tinea in the groin and he started applying steroids. Steroids are immunosuppressive, so they suppress the tinea, and when they suppress the tinea, the itching becomes less, the redness becomes less, but the tinea is still persisting and gradually it is increasing and increasing. And such type of tinea which is hidden, which is less itchy, less red due to application of steroids, is known as tinea incognito. सो स्टीरॉइड एप्लीकेशन के बाद जो टीनिया डेवलप होता है उसको बोलते हैं टीनिया इनकॉग्निटो. रिमेंबर दिस पॉइंट. सेंट्रल क्लियरिंग is feature of tinea, mainly tinea corporis, but answer is not tinea corporis. Why? Because steroid is applied. If steroid is applied over corporis or cruris or any type of tinea, it becomes tinea incognito. Central scarring is seen in lupus vulgaris. Central crusting is seen in leishmaniasis. So all these are very important points already asked. Central clearing, tinea; central scarring, lupus vulgaris; and central crusting, leishmaniasis. Tinea pedis, also known as athlete's foot, occurs over foot. Tinea cruris occur over body. Over body, no, sorry, over groin, tinea cruris, and tinea corporis over body. But if you apply steroid over any tinea, it becomes tinea incognito. And here the patient has applied steroids. Steroids are immunosuppressive. They are anti-inflammatory. So redness comes down, itching comes down. And due to this, the tinea becomes tinea incognito. Remember this point. Very important, recent question. Okay, so this was the most important clue here, that the patient has less itchy and less red since using topical steroids. As soon as you see steroid, go and mark tinea incognito. A large growth over anal area. So identify the condition as shown in the image, and what you can see in the image, there is a bulky, very large growth. If you see the surface of this growth, the growth is rough. Rough means verrucous. So a rough verrucous, that is a warty growth in anogenital area. So around anal and genital area. This is a case of condyloma acuminata, also known as anogenital warts. Why it is not hemorrhoids? Because hemorrhoids are due to dilatation of the vessels and they are smooth and not rough. So they are not rough surface, they are smooth surfaced. Condyloma lata are seen in secondary syphilis. They are flat lesions and not such big outgrowths. They are flat lesions. And Bowen's disease appears erythematous and it does not become such large growth. Large growth can be seen in anogenital warts, that is condyloma acuminata. Now remember that when the growth becomes so large, we give it another name, and that is a very giant condyloma acuminata is also known as Buschke-Lowenstein tumor. So this is also known as Buschke-Lowenstein tumor. Yes, Dr. Debake have already answered this, Buschke-Lowenstein tumor. And when it becomes so large, the treatment is excision. Any surgical therapy can be done. So surgical excision is done. But when it is not so large, then what is the treatment? That is anogenital warts. What is the treatment? Treatment is imiquimod. If imiquimod is not given, then podophylotoxin. Both are teratogenic. So what is the treatment in pregnancy? Cryotherapy. This question was also recently asked. So cryotherapy in pregnant patients, if it is anogenital wart. If patient is not pregnant, then imiquimod. If imiquimod is not mentioned, then podophylotoxin. And if it is very large, that is giant anogenital wart or Buschke-Lowenstein tumor, then surgical excision. What is the cause of anogenital warts? Anogenital warts are caused by human papilloma virus 6 and 11 subtype. So 6 and the 11 subtype is the most common agent which cause anogenital warts. Yes. So Urta Darinda is saying minus 196 degrees centigrade. Correct. So in cryotherapy, we use liquid nitrogen, and this liquid nitrogen is very cold, minus 196 degrees centigrade. 6 and 11. If both are given in separate option, choose 6. 6 is the most common. Next question. A patient who is already on MDT, multi-drug therapy for leprosy, presents with edema of pre-existing lesions and neuritis. Neuritis means inflammation of nerves and edema of pre-existing lesions. What is the treatment of choice? Stop MDT. Will you stop MDT? No. So if a patient is suffering from leprosy, where already it is written that patient is taking MDT, we will never stop MDT. We will continue MDT. So we are not going to stop MDT. WHO says that you have to continue MDT. Now, the problem here is that the patient is having leprosy and he's taking treatment for that. That is, he's taking MDT, but developing edema of the lesions and inflammation of the nerves. So why this is happening? All this is happening because of lepra reaction. This lepra reaction can be of two types, type 1 lepra reaction and type 2 lepra reaction, which is a hypersensitivity reaction. This is type 4 hypersensitivity, this is type 3 hypersensitivity. And when patient develops lepra reaction, the drug of choice is steroids in type 1 as well as type 2. In both, the drug of choice is steroids. So we will continue MDT, but not add thalidomide. We will add steroids, which is the drug of choice for lepra reaction. So because patient is having leprosy, we will give MDT and we'll continue MDT. And now patient is having lepra reaction, so we will give steroids also. So add steroids. Answer becomes continue MDT and add steroid. Now, Now remember that thalidomide also have role in the treatment of lepra reaction, but it is not drug of choice. So drug of choice is steroids, but the patient where we cannot use steroids, you can give thalidomide. But remember, it is not used in type 1. It is only effective in type 2. So in type 2, you can use thalidomide, but it is not drug of choice. Why? Because it is a teratogenic drug. The side effect is it is teratogenic. So thalidomide can also be used, but the drug of choice is steroids, and they are asking what is the treatment of choice. So you will give steroids. Some more important points to remember about leprosy are satellite lesions, punched out lesions, inverted saucer shaped lesions. So remember that satellite lesions are seen in BT type of leprosy. Punched out lesions and inverted saucer shaped lesions are same. Okay, and both these are seen in BB type of leprosy. So already these questions have been asked. So remember that in BT, satellite lesions are seen and punched out or inverted saucer shaped lesions are seen in BB type of leprosy. Also remember, BB type is the rarest type of leprosy and BT type is the most common type of leprosy. So the most common type of leprosy is BT and the rarest type is BB. So Dr. Debake is saying that BB punch marti hai. Yes, if you want, you can remember this, that BB punch marti hai. So punched out lesions are seen in BB type. And you can remember T for T. So BT, satellite. Satellite I also have T. So you can remember BAT, SAT. Okay, so SAT, satellite, BAT, BT. किसी को बीबी नहीं मिलती है तो पंच क्या मारेगी? Somebody was writing something like that. Okay. तो जब बीबी पंच मारती है तो आप उल्टे गिरते हैं, ठीक है? सो इन्वर्टेड, ठीक है? तो बीबी पंच मारती है, आप उल्टे गिरते हैं, तो बीबी टाइप punched out lesions, inverted saucer shaped lesions. Coming to the next question. Match the following type of scales with their associated condition. Again, a very important question, types of scales. So types of scales and the conditions. Just now I told you, cholerated scales are seen in Pityriasis rosea. Do you remember? Cigar, that is cigarette paper like, or cholerated scales. They are seen in Pityriasis rosea. Silvery white scales are seen in psoriasis. Brany scales. Brany scales are very fine like powder, and powdery scales are feature of Pityriasis versicolor. Mica-like scales are seen in Pityriasis lichenoides chronica, and fish-like scales are seen in ichthyosis, where ichthyo means fish. So answer becomes A. So these are some of the very important scales to remember. Cholerated scales are seen in Pityriasis rosea. Silvery white scales are seen in psoriasis. Mica-like scales are seen in PLC, that is Pityriasis lichenoides chronica. Brany scales are also known as powdery scales. They are seen in Pityriasis versicolor, and fish-like scales are seen in ichthyosis. So pityriasis rosea is a separate entity and roseola infantum is separate. So 8-year-old boy presented to OPD with weakness in his lower limbs and a rash over the eyelid. So there is weakness in the lower limbs and rash over the eyelid. The biopsy shows inflammation in the muscle. So there is muscle inflammation. Do you know what is the word used for inflammation? Itis. So this is dermatomyositis. Why we call it dermato? Because here skin involvement is also seen. And why myositis? Because there is inflammation of the muscle. So this is a case of dermatomyositis where derma involvement is also seen and muscle involvement is also seen. There is inflammation in the muscle due to which patient have weakness in the lower limbs. Patient is unable to walk properly or sometimes climb the stairs properly. So dermatomyositis is a condition where these two entities are present together as mentioned in the question. So clearly in the question, it is written weakness in the lower limbs, inflammation in the muscle, myositis, and derma is also involved because there is rash over the eyelid. Now, what is the finding shown in the image below? They are saying image have certain rashes, and these rashes are over the knuckle of the patient, over the knuckle and the interphalangeal joints, and the knuckle is involved. So what are these? These are Groton papules, which are seen in dermatomyositis. Now remember that heliotrope rash are also seen in dermatomyositis, but answer is not heliotrope rash. Remember, the heliotrope rash which are seen in dermatomyositis are these which are present over the eyelid. So heliotrope rash are seen over the eyelid of the patient. They are also seen in dermatomyositis, but this is not the answer because what they are asking the findings shown in the image. In the image, these knuckle areas, the rashes, these are what? These are Groton's papules. Shawl sign. Shawl shine is not the answer, but it is also seen in dermatomyositis. And it is seen generally over the upper back. So over the upper back, shawl sign is seen. So there is a rash which develops over the shoulder or the upper back. It appears as if the patient is wearing a shawl. Okay, heliotrope rash is the one which develop over eyelid, and Groton's papules are the one which develop over knuckles of the patient. All these three are seen in dermatomyositis, but the answer is D, Groton's papules, because these are the one which are present over the knuckle of the patient. Now remember, because questions have been asked on these points, that's why remember shawl sign, that is the rash over the upper back or the shoulder where we wear shawl. Heliotrope rash are, why we call them heliotrope? Because heliotrope is a type of a flower which is slightly purplish in color. So these are purplish rash which are present around eyes, and Groton's papules which are present over knuckle. All these are seen in dermatomyositis. Now 35-year-old female presents with a high body mass index. So high body mass index means weight is more of the patient in respect to the height of the patient. Okay, so what is BMI? It is weight in kg upon height in meter square. So height in meter square and weight in kg. So BMI is high, that means patient is obese. Presented with a lesion over the neck, and here you can see that dark hyperpigmented velvety looking skin over folds. Which folds? Neck folds. What is the likely cause? Now, in obese individual, if you get hyperpigmented velvety appearance over neck fold, it is acanthosis nigricans. Acanthosis nigricans is the condition. Now, acanthosis nigricans can be caused by obesity, and this obesity can be due to metabolic syndrome. Yes, metabolic syndrome, because metabolic syndrome itself is associated with central obesity, isn't it? It can also be seen associated with diabetes, insulin resistance. So patient can be obese, patient can be diabetic, patient can have metabolic syndrome or insulin resistance, and due to this, patient can develop darkening of the folds known as acanthosis nigricans. And later on, over this fold, patient can also develop these skin tags. These are known as, you can see these projections of skin coming out. So these are known as skin tags or acrocordons. Never question have been asked on acrocordons. That is not important. So this is not important. But remember, acanthosis nigricans is associated with metabolic syndrome, diabetes, obesity. Among them, the most common cause is obesity. So what will be the treatment? The treatment will be weight loss. So you have to ask the patient to lose some weight. Once the patient reduces the BMI, so BMI comes down, the pigmentation also comes down. 40-year-old women presented with diffuse hair loss. Diffuse hair loss. That means there is not a patch of hair loss. Whole scalp is involved. Diffuse hair loss for 3 months. She has a history of COVID fever 8 months back. What is the most likely diagnosis? So patient had fever. Few months later, developed diffuse hair loss. This is a case of telogen effluvium. Telogen effluvium is a type of diffuse hair loss where patient complains of excessive hair loss generally 3 months after typhoid fever, COVID fever, or any chronic illness, even after pregnancy. It could be typhoid fever or it could be COVID fever. So after fever or pregnancy or any chronic condition, when patient develop diffuse hair loss, that is telogen effluvium. What is anagen effluvium? Anagen effluvium is complete hair loss seen after chemotherapy. So when the patient lose all the hair follicles, you must have seen patients who have undergone chemotherapy, they go bald. So that is known as anagen effluvium. Tinea capitis is fungal infection of the hair follicles leading to sometimes boggy swelling known as carrion. So here there is no swelling. Trichotillomania is a psychiatric condition where patient have tendency to pull the hair follicle. So patient keep pulling the hair follicle from one particular area. There is a patch of hair loss seen in a psychiatric patient. That is trichotillomania. And female pattern androgenetic alopecia have two patterns. So female pattern androgenetic alopecia have two patterns. In first one, Ludwig pattern, and in the other one, Olsen pattern. Both these are seen in females. And in males, there is receding frontal hairline and loss from the crown. This is Hamilton pattern. So these are three patterns of androgenetic alopecia. In females, Ludwig and Olsen pattern, that is the central part is involved, or where the females part their hair follicles, that part is involved. And in males, there is frontal receding hairline and loss from the crown. This is Hamilton pattern. So all these are different patterns of androgenetic alopecia. So here there is no role of fever, but because fever is mentioned here, so that's why answer is not female pattern. It is telogen effluvium. Coming to the next question, can you identify the condition? What are the important clues mentioned here? Foot, swellings, Not one swelling, there are multiple swellings. Multiple swellings or tumefaction. In these swellings, you can see there is an opening present. So there is an opening which is present. So sinus. Through this sinus, some discharge comes out. Discharge. And this discharge can have granules. All these are pointing towards Madura foot. That is Madura mycosis. So Madura mycosis or Madura foot presents with multiple swellings. The most common site is foot, and over these swellings there is sinus through which discharge and granules are coming out. Why the answer is not chromoblastomycosis? Because chromoblastomycosis presents with rough growths, verrucous growths, and so is tuberculosis verrucosa cutis. So both these, they present with very rough growths instead of swellings. And cellulitis is a bacterial condition and it is a very toxic condition. So generally patient have fever, malaise, systemic features with swelling, but these swellings are not multiple. It is a single large swelling with diffuse borders. So diffuse borders, a large swelling with systemic features is seen in cellulitis. So all these are missing here. So that's why it is Madura foot. Now Madura foot can be of two types: eumycetoma and actinomycetoma. So this mycetoma can be of two types, U and actinomycetoma. Eumycetoma is caused by fungus like Madurella mycetomatis, and actinomycetoma is caused by bacteria like Nocardia. So remember, it can be caused by both fungus and bacteria, that is eumycetoma and actinomycetoma. Next is all are seen in the condition except. So among these four options, three are seen in this condition. And if you look at the image, what are the important clues which are present? The lesion is very small. It is less than 0.5 centimeter in size. It is papule. It is not red in color. It is purple in color. So papule, purple, pointing towards lichen planus because it is pigmented, and these papules are slightly polygonal. This is not psoriasis. Munro's microabscess is seen in psoriasis. Psoriasis is red in color, erythematous, and it have lot of scaling, silvery white scaling. So in the image, you can very easily make out that it is not psoriasis because it is not red, it is not having scaling, and Munro's microabscess are seen in psoriasis. So this becomes the answer. This is not seen in lichen planus, while these three are seen in lichen planus. So very important point, Munro's microabscess is seen in psoriasis, and from the image you can very clearly make out this is not a case of psoriasis. Now what are these points? Let us discuss them individually. I already told you, Wickham striae, a white reticulate pattern which is seen over the lesions of lichen planus. This is known as Wickham striae. So if you examine these lesions carefully, you will find a reticulate pattern over it that is known as Wickham stripe. Now, if you take biopsy from here, you will find basal cell degeneration. That is, the cells in the basal layer, stratum basale, are degenerating. So these degenerating basal cells are known as cavity bodies, also known as colloid bodies. They are seen in lichen planus. So this is also a histological finding of lichen planus. Saw-toothed acanthosis. If you remember, I told you acanthosis is thickening of stratum spinosum. And at places it is thickened. Like here it is thickened, then it is normal. Then here it is thickened, then it is normal. Then here it is thickened, then it is normal. Then here it is thickened. So this is known as wedge-shaped acanthosis, that is thickening of stratum spinosum. So this wedge-shaped thickening of stratum spinosum is seen, and because it is wedge-shaped, something like this, it appears like a saw tooth. So this is also known as sawtooth acanthosis. Both these are features of lichen planus. So cavity bodies or colloid bodies, which are due to degeneration of the basal cell, and saw-toothed acanthosis, both are histological findings which are seen in lichen planus. So all these are features of lichen planus. Yes. So these are apoptotic degeneration of the basal cells. Now patient presents with lesions shown below. She later developed arthritis. So in the beginning, on the first visit, patient had such lesions. Later on, developed arthritis. What is the best treatment in this scenario? So what is happening? The patient is having red. All of you can see it is red erythematous. And if you closely see, there is a scaling also, with scaling over back of the neck, that is extensors in the scalp also. So patient is having erythematous scaly lesions. Scaling is silvery white lesions. So this is psoriasis. Can patient develop joint involvement? Yes, patient can develop psoriatic arthritis. So later on, the disease aggravated and developed joint involvement, that is arthritis. Now, what is the best possible treatment? Best possible treatment. So when patient develops psoriatic arthritis, what is the drug of choice? The drug of choice is methotrexate. So drug of choice for psoriatic arthritis is methotrexate. The drug of choice for erythrodermic psoriasis is also methotrexate. So methotrexate is a drug of choice for arthritis and erythrodermic psoriasis. But if you see this option, acitretin, drug of choice for pustular psoriasis is acitretin. So acitretin is the drug of choice for pustular psoriasis. Rituximab is monoclonal antibody used in pemphigus. So this one is used in pemphigus. Cyclophosphamide is also used in pemphigus in the form of DCP pulse, dexamethasone cyclophosphamide pulse. This is also used in pemphigus. So cyclophosphamide and rituximab are used in pemphigus. While methotrexate and acitretin are used in psoriasis, among them, methotrexate is the drug of choice for psoriatic arthritis and erythrodermic psoriasis, while acitretin is the drug of choice for pustular psoriasis. Remember that acitretin is teratogenic. Because it is teratogenic, if patient develops pustular psoriasis in pregnancy, then you will not give acitretin. Pustular psoriasis in pregnancy is also known as impetigo herpetiformis. And here, the drug of choice is steroids. If a steroid is not given, then cyclosporin. So if simply pustular psoriasis is written, then mark acitretin as the answer. But if pustular psoriasis in pregnancy is written, then we don't give acitretin, we give steroids. If a steroid is not there, you can give cyclosporin. Both can be used in pregnancy. And when pustular psoriasis develops in pregnancy, the name given to this condition is impetigo herpetiformis. This is another name of pustular psoriasis in pregnancy. Which sign is shown in the given picture? And in the picture, what you can see? You can simply see lesions present in straight line. So linear lesions. So maybe patient have scratched, and along the line of scratch, multiple lesions have developed in a linear fashion. So linear lesions along trauma or scratch is known as isomorphic phenomena. Another name is Koebner's phenomena. So Koebner's phenomena is also known as isomorphic phenomena. And what is Koebner's phenomena? It is linear extension or the linear lesions along the line of trauma. Auspit sign, I already told you, is seen in psoriasis. Dermographism is seen in urticaria. And Darrier sign is seen in urticaria pigmentosa. Urticaria pigmentosa is also known as cutaneous mastocytosis. So in cutaneous mastocytosis, that is urticaria pigmentosa, Darrier sign is seen. All these are important. Already questions have been asked on each one of them, and that's why I have included them here in this question. So Auspit sign is important sign of psoriasis. Dermographism is seen in urticaria. Darrier sign is seen in urticaria pigmentosa, which is also known as cutaneous mastocytosis. And Koebner's phenomena is linear extension of the lesions along the line of trauma. And it is seen in which condition? Remember, Koebner's phenomena can be of two types: true Koebner's and false or pseudo Koebner's. True Koebner's is seen in psoriasis, vitiligo, and lichen planus, while false Koebner's is seen in warts and molluscum contagiosum. Both these are infective conditions. As you know, molluscum contagiosum is caused by pox virus, and warts are caused by human papillomavirus. So in infective conditions like warts and molluscum, false Koebner's is seen, while in immunological conditions like psoriasis, vitiligo, and lichen planus, true Koebner's is seen. So it is easy to remember. If infective condition is mentioned, then it is false covenous. If immunological condition is mentioned, then it is true covenous. In both, the same thing is happening. That is, multiple lesions develop along the line of trauma. So they develop in linear fashion. In the next question, they are saying that a truck driver presents with non-pruritic lesions all over the body, including palm, with oral ulcer. What is the most probable diagnosis? Now, whenever you read these clues like truck driver, history of contact, these are suggestive of sexually transmitted infections. Because truck drivers, they are out for many days, sometimes months. And if a patient is having history of contact, then they have more chances to develop sexually transmitted infections. Now, in this patient is developing non-itchy lesions all over the body, as you can see in this image, including the palms. And there is oral ulcer as well. What is the most probable diagnosis? The answer is there is only one sexually transmitted infection mentioned here, and that is secondary syphilis. So answer is secondary syphilis. Drug eruptions generally are due to drugs, and there is no drug history mentioned. Tan and Steven-Johnson syndromes are also usually associated with drugs. The common drugs can be anti-epileptic drugs like carbamazepine. So because there is no history of drugs given in the question and the patient is a truck driver, rashes are developing and ulcer is developing, probably this is secondary syphilis. What is primary syphilis? Primary syphilis is the first lesion which develop after history of contact, and that is usually in the form of genital ulcer. So primary syphilis presents with genital ulcer. But when this genital ulcer heals, patient can later present with secondary syphilis. So secondary syphilis develops after genital ulcer have healed. So they present in the form of rashes. Rashes can be over the body, they can be over the palm. Now, when the rashes are over the body, they look like the rashes of or the lesions of psoriasis or pityriasis rosea. So that's why psoriasis and pityriasis rosea is the differential diagnosis for syphilis. Now, when they develop over palm, they are very tender to touch. When you palpate them, they are tender. There is tenderness. This is known as Buschke-Ollendorff sign. So Buschke-Ollendorff sign is seen in secondary syphilis. What is Buschke-Ollendorff sign? On pressing the lesions of secondary syphilis, there is deep dermal tenderness. Condyloma lata are also seen in secondary syphilis. Condyloma lata. These are highly infectious. So these are highly infectious lesions of secondary syphilis. They are present over genital areas and they are flat. So patient can present with rashes. Patient can present with condyloma lata. They can also have oral ulcers and they are also painless. So because in the question it is written patient is having painless oral ulcer, rashes, and patient is a truck driver, the diagnosis becomes secondary syphilis. If the patient is having genital ulcer, then answer becomes primary syphilis. Because this genital ulcer is hard, we also call it hard chancre. So hard chancre or genital chancre is seen in primary syphilis, while rashes, condyloma lata, oral ulcers are seen in secondary syphilis. I hope this is clear. If you look at this image, can you tell me which investigation has been done here? Immunofluorescence. Which immunofluorescence? Direct immunofluorescence, DIF. So they have done direct immunofluorescence. 35-year-old female patient had developed vesicobullous disorder having vesicles and bullous lesions, which shows fish net-like appearance on direct immunofluorescence as shown in the image below. The diagnosis of pemphigus vulgaris was made. So diagnosis is also written. So patient of pemphigus vulgaris can present with fish net-like appearance on DIF. We all know that. Which among the following describes the disease? Now let us read these question options individually. It is autoimmune disorder. Yes, pemphigus vulgaris is an autoimmune disorder. Where antibodies are formed? Yes, in pemphigus antibodies are formed. So in pemphigus vulgaris, it is an autoimmune disorder and here antibodies are formed. These are formed against hemidesmosome? No. They are formed against anti-connexon antibodies? No. In this disease, poorly formed cell adhesion molecules are there. The cell adhesion is hampered, but it is not poorly formed. Actually, the antibodies are formed against desmosome, which destroy desmosomes, due to which the cell adhesion is hampered. So these antibodies are formed against desmoglin, and desmoglin is protein present in desmosome. So answer becomes D. So remember that pemphigus vulgaris is a vesicobullous lesion. Here vesicles and bulla are seen. The investigation of choice is DIF. When you do DIF, fishnet-like pattern is seen. And what is the problem? Here IgG antibodies are formed. These are generally IgG antibodies. So IgG antibodies are formed against desmoglin, which is a protein present in desmosomes and not hemidesmosomes. So answer is D. What are other features of pemphigus which you need to remember? Pemphigus, the most common is vulgaris. The other one is foliaceous. Here mainly desmoglin 3 is involved, but desmoglin 1 can also be involved. Here only desmoglin 1 is involved. If you do histology, row of tombstones appearance is seen. If you do DIF, fishnet like pattern is seen, and clinically Nikolsky sign is positive. So row of tombstones appearance, fishnet like pattern, Nikolsky sign is positive. Here oral mucosa involved. Here it is spared. Skin can be involved in both. So skin can be involved in both vulgaris and foliaceous, but here mucosa is involved. Here mucosa is spared. This is a very important clue to differentiate vulgaris and foliaceous. While these three findings can be seen, they sometimes ask you row of tombstones appearance of fishnet-like pattern is seen in, or Nikolsky sign is positive, and answer is pemphigus. A male child with mild painful swelling over scalp for 3 months. So this child is having painful swelling over scalp since 3 months. Patient has a dog pet at home. Probably dog से infection आया है. What is the diagnosis? So tender, that is painful. boggy, that is soft to touch, swelling over scalp of a child, because it is commonly seen in children. All these are clues pointing towards which condition? Tinea capitis. Which type? Carrion. So answer here is carrion. Remember that answer is not folliculitis, because folliculitis is infection of the hair follicle. So if this is the hair follicle, if infection is present here, it is localized to one or few hair follicles around it. Abscess is very painful. So abscess is very painful, and there, if you pull the hair follicles, patient feel a lot of pain. But here in tinea capitis, they easily come out. So there is easily pluckable hair follicles. Another clue is that when there is bacterial abscess, there is a lot of inflammation, like collar, rubber, dubber, lot of swelling, lot of pain. The area becomes warm, patient have fever, malaise. So all these features are absent. So this is not abscess. Sebaceous cyst is generally painless. There is only collection of sebum within the cyst unless there is infection. That is infected sebaceous cyst. So this is generally painless. So this is also not the answer. The answer is carrion. So carrion generally presents something like this. That is a tender boggy swelling. It is commonly seen in children and they have easily pluckable hair follicles. If you want to confirm your diagnosis, you can do Woods lamp examination. Green fluorescence is usually seen. The drug of choice for tinea capitis is oral griseofulvin. So oral griseofulvin is the drug of choice for carrion or tinea capitis. Green fluorescence is seen. Easily pluckable hair are seen. Tender boggy swelling is seen. In a child, all these are important clues pointing towards carrion or tinea capitis. Now remember that in microbiology, you must have read about dermatophytes which cause tinea infection, and these dermatophytes can be zoophilic, zeophilic, or anthropophilic. So zoophilic, geophilic, and anthropophilic. Zoophilic, when zoo, animals live in zoo. So when the infection happens from animal to man. Geo means soil. So from soil to man. And anthropophilic, when man to man. So this tinea infection, which is caused by dermatophytes, is spread via three ways, either from animals or from soil or from man to man. So what is the importance of writing this sentence here? Patient have a dog pet at home. They want to tell you that the infection was present in the dog, in the pet, and later on that man was involved, that child was involved. So animal to man. So probably which dermatophyte have caused it? Zoophilic dermatophyte have caused it, because zoophilic are the one which move from animal to man. Zoo and geo cause inflammatory variant of tinea, while this one cause non-inflammatory variant. And carrion is inflammatory type. If you remember, tinea capitis is of two types. We have already written in the notes, inflammatory, non-inflammatory. Examples of inflammatory are carrion and favus, and non-inflammatory are black dot and gray patch. So now you know that carrion and favus are caused by inflammatory variant, and inflammatory variants are zoo and geo, while Non-inflammatory variants are black dot and gray patch, and they are non-inflammatory, generally caused by anthropophilic. Okay, so this is the reason why they have written that sentence. Okay, that it is inflammatory type of tinea capitis. So you can choose carrion or favors from the answer. In the next question, they are saying 1-year-old child presents with eczematous dermatitis over face as shown in the image. His mother have history of bronchial asthma. So there is a family history of bronchial asthma and the patient is having dermatitis. This is which dermatitis? Eczematous dermatitis, seborrheic dermatitis, airborne contact dermatitis, or atopic dermatitis? Answer is very clear. Answer is atopic dermatitis. Why? Because in the diagnosis of atopic dermatitis, these two scientists, Hannifin and Rachka, they gave 4 major criteria. What are the 4 major criteria of atopic dermatitis? It is a very itchy condition. It is a chronic condition. Family history of atopy is present and it involves usually flexors in adults and can involve extensors and face in infants. So generally this condition occurs over flexors, but in infants, because these infants crawl, their extensors and face can get involved. So now see the clues. Face involvement. Family history of allergy. Mother having history of bronchial asthma. So 2 important clues are written there. Face, mother having history of bronchial asthma. So this is a case of atopic dermatitis. If we talk about airborne contact dermatitis, remember airborne contact dermatitis is due to Parthenium. Parthenium, that is Congress grass. Seborrheic dermatitis, I already told you, is known as cradle cap in infants. And eczematous dermatitis, when there is infection, we call it infective eczematous dermatitis. Infection can be of 2 types: bacterial, usually Staph aureus, and viral, usually herpes. So patient, when having dermatitis, it can be atopic dermatitis or any type of dermatitis, when develops infection, it can be bacterial infection or a viral infection, we call it infective dermatitis. So answer here is atopic dermatitis. Very important clue is that the mother is having history of bronchial asthma. If cubital fossa, popliteal fossa is shown in a grown-up child or adults, then those are the common sites. And in children, actually extensors and face can get involved. So this is a case of atopic dermatitis. Somebody here, Ashik Ali, is asking that, sir, what is the treatment of alopecia areata? So alopecia areata, we are coming. That is the next question. Last question is alopecia areata. There, I'll let you know the treatment for that. So 24th, a patient with a known case of tuberculosis has taken multiple medications. Yes, because whenever patient have tuberculosis, patient has to take multiple medications. ATT, anti-tubercular therapy. What are anti-tubercular first-line drugs? Isoniazid, rifampicin, ethambutol, pyrazinamide, streptomycin. Now, among these, patient must have taken these drugs. Now he has presented with a given image what is the most appropriate diagnosis and what the patient is having. Almost complete skin involvement. Patient has developed a drug reaction. As you can see, there is mucosal involvement. So there is mucosal crusting. There is epidermal separation, which is hemorrhagic. As you can see, a lot of brown color or blood is present. So hemorrhagic epidermal separation, almost whole skin is involved. More than 30% of the skin is involved. This is a case of toxic epidermal necrolysis. Why it is not Steven-Johnson syndrome? Because here less than 10% skin is involved. Here in the image, you can see almost complete skin involvement is there. Why it is not fixed drug eruptions? Because fixed drug eruptions are fixed at a particular site. They do not involve whole body. They are at a particular site. Okay, so fixed drug reaction generally occur at a particular site, like it can occur around lips or it can occur around genitals. Those are also related to drugs. And anaphylaxis is a life-threatening condition where patient can develop a lot of lip swelling or there is swelling in the airway due to which the patient is unable to breathe. Okay, so a lot of swelling is present. So these are not the answer. Answer is 10 because there is hemorrhagic epidermal separation and hemorrhagic mucosal crusting, and there is intake of drug which is mentioned. And the drugs which are here are anti-tubercular drugs. And among these anti-tubercular drugs, these three are the culprit which can cause 10. So isoniazid, rifampicin, and ethambutol, all three are known drugs which can cause 10. There are other drugs also. So the drugs which can cause 10, that is toxic epidermal necrolysis, are anti-epileptic drugs like carbamazepine, anti-gout drug like allopurinol, then NSAIDs, non-steroidal anti-inflammatory drugs like piroxicam, then antibiotics like cotrimoxazole, vancomycin, doxycycline, then anti-tubercular drugs like isoniazid, rifampicin, ethambutol. So there are so many drugs which can cause it, but in majority of the cases, the culprit are anti-epileptic drugs like carbamazepine, and tuberculosis can also cause tubercular meningitis. And there we need to give anti-epileptic drugs also. So all these drugs can cause toxic epidermal necrolysis. How you're going to separate? If almost whole body is involved, more than 30% of the skin, then mark answer as 10. But if the similar thing is happening in less than 10% of the body, then answer becomes Steven-Johnson syndrome. So coming to the last question, a male patient is suffering from alopecia as shown in the image. What you can see in the image, there is a patchy hair loss, patchy alopecia. Which of the following nail change is likely to be associated? So patchy hair loss is feature of alopecia areata. Alopecia areata. Now, alopecia areata is not just associated with hair loss, it is also associated with nail changes. What are the nail changes which are seen in alopecia areata? Patient can present with nail pitting. So, nail pitting is seen. Pigmentation of the nail can be seen. Yes, pigmentation of the nail can be seen, but not in alopecia areata. It is seen in patients who are taken minocycline. So patients who are on minocycline therapy can develop pigmentation or darkening of the nail. Pterygium of the nail is seen in? It is seen in lichen planus. Yellowish discoloration of the nail can occur? Yes, it can occur in yellow nail syndrome. Yellow nail syndrome is a condition where nails become yellow along with respiratory issue. So patient have lung issues as well. So with systemic conditions, sometimes patient's nail can appear yellow. So all these can be seen, but in alopecia areata, the nail changes associated are pitting of the nail. Now remember, that this nail pitting can be of two types: regular pitting or irregular pitting. This regular pitting is generally superficial, and this irregular pitting is generally coarse or deep. This is seen in alopecia areata, while irregular deep pits are seen in psoriasis. So pitting is seen in alopecia areata also, it is seen in psoriasis also, but how you're going to differentiate? Here it is superficial and regular, while in psoriasis it is irregular and deep. So one of the student was asking that, what is the treatment of alopecia areata? Now remember that alopecia areata is an autoimmune condition. So because it is autoimmune condition, we need to treat it with immunosuppressive drugs, like you can give steroids. Steroids can be given topically, like topical clobetasol. You can give injectable. The injectable treatment is given in the patch itself. A long-acting steroid is used, like triamcinolone. And oral steroids or systemic steroids can be given, like betamethasone. Other than steroids, you can use phototherapy, drugs like levamisole, which is immunomodulator. You can also use topical contact irritants. They are not very commonly used, but they have role. When we apply topical contact irritants, what happens? The antibodies which are actually formed against the hair follicles, instead of acting against the hair follicles, they start acting against these irritants, and the hair follicles start growing. So sometimes you can apply contact irritants over the affected area. So these are various therapies which can be used in the treatment of these cases of alopecia areata. So we have tried to include most of the important questions and the topics in this session. I hope this session was useful for all of you. So my best wishes are with all of you. If you have not yet revised dermatology, at least go through these 25 questions, and various other topics also we have included in the explanation part, and try to revise the notes before going to the examination hall. And if you simply revise my notes, at least you will be able to recall the answers in the examination hall, and you will be able to pass this exam. So my best wishes are with all of you. Thank you very much. All the very best. See you. Also, if you want to message me, or if you have any doubt, this is my email address: manishsoni2003@gmail.com. So Manish Soni 2003@gmail.com. If you really like the session, then you can simply type my name on the Google search, Dr. Manish Soni. You will find my Google profile. So you can share a 5-star rating there. And thank you for wishing me Guru Purnima. So my best wishes are with all of you, and hope you pass this exam. All the very best. See you.